I take them in? Okay.
Welcome, colleagues and friends, to the session today. I see many people are continuing to trickle in, so we'll just give it another minute and then we will get started. Okay, good morning, afternoon, evening, colleagues and friends, welcome. Assalamu alaikum. My name is Dr. Nadia Akhtir. I'm a scientist at Johns Hopkins University, and I will be the moderator for today's session. I would like to welcome you to 1 year on the pervasive health challenges in Afghanistan, a 4-part series brought to you by Johns Hopkins University. Today's session is called 20 Years of Healthcare Delivery in Afghanistan, Evolution, Challenges, and Opportunities. Let's get started. In terms of an agenda, we will spend about 5 minutes setting the scene and giving some background information, and then we'll move right into a structured dialogue with our esteemed panelists, where they will discuss priority challenges and solutions from their perspectives. Then we will spend about 20 minutes together in a question and answer session, and then in the last 5 minutes, we will wrap up. A few reminders for the webinar. Please do put your questions in the Q&A feature, not in the chat. We will collate them from the Q&A and we'll respond to them during the session. We may not get to all questions, but we'll try to get to as many as possible. We will be recording the session and then have it translated to Pashto and Dari, and later we will send out the recording. And please do join us for the other sessions in the series. The second one on reproductive, maternal, newborn, and child health, the third one on nutrition, and the fourth one on sustainable development. The links will be available in the chat momentarily. A little bit of scene setting before we get into the discussion. In 2001, Afghanistan emerged from several decades of war and instability with a shattered country, shattered public institutions, including the healthcare system, and some of the worst health and survival indicators in the world. In the 20 years that followed, with communities eager to rebuild and a large influx of donors and NGOs, Afghanistan made remarkable successes. Among these, some notable areas are the introduction and rollout of the basic package of health services and the accompanying essential package of hospital services that were rolled out countrywide and contracted through national and international NGOs and in through the strengthening mechanism in select provinces. Several national vaccination, malaria, TB control, and nutrition programs were also prominent during this time. There was successful training and deployment of healthcare workers, especially in rural areas, such as through the Community Midwifery Education Program, where from a baseline of 211 midwives in 2005, the program was able to deploy over 5,000 midwives by 2018. There was also strong stewardship of the Ministry of Public Health in coordination, communication, and monitoring, and huge investments in data systems, such as the Health Management Information System and large-scale surveys, and using data for quality control and decision-making, such as tools like the Balanced Scorecard. Naturally, this led to improvements in many health outcomes, and I'll just highlight a couple here. The maternal mortality ratio over the last 2 decades has dropped. It's estimated to have dropped nearly 60%, and you see the figures there. Under 5 mortality declined by more than 50%, and the coverage of essential interventions such as access to antenatal care and skilled birth attendance also doubled over this period. Despite these types of gains, many challenges remained in Afghanistan, and many of these issues, sadly, were further exacerbated after the political change in August 2021. Today, there is an ongoing humanitarian crisis in Afghanistan with regards to poverty, health, nutrition, and education, and many other areas. And effectively, the brain drain has shifted and lost many health professionals and qualified people from Afghanistan, and the population dynamics have shifted in Afghanistan. And as a result, the burden of disease profile has also changed. There are currently limited donor resources, and sadly, the future of Afghanistan is uncertain. In the spirit of hope and opportunity for Afghanistan, the goal of this session today is to bring together key stakeholders to discuss these challenges and identify solutions for protecting the health system and protecting the health of families and communities in Afghanistan. Without further ado, let's go ahead and get started. I would like to introduce our panel of colleagues who will be presenting today and discussing amongst themselves and with all of you. We are joined by Dr. Miki Chopra, who is the Global Solutions Lead for Service Delivery at the World Bank and has in fact worked on Afghanistan for over 7 years. We are also joined by Dr. David Peters, who is the Professor and Chair of International Health at Johns Hopkins University and has in fact led the third-party monitoring of the BPHS and EPHS in Afghanistan as lead investigator for over a decade. We're also joined by Dr. Jamshed Tanoli, who is currently on the ground coordinating over 60 NGOs who are actively providing services to Afghans in need. He's the Health Cluster Coordinator on behalf of the WHO based in Kabul. And last but not least, we are joined by Dr. Ahmadjan Naeem, who is the former Deputy Minister of Public Policy and Planning in the Ministry of Public Health of Afghanistan, and currently is the Senior Technical Advisor at MSH, and he has spent over 17 years working with MOPH in Afghanistan. Next slide, please. Thank you. So we will go ahead and start with our structured dialogue. Just a few notes on this part of the session. You will notice that the participant responses will be timed. There is a timer up on the right. The timer will begin as soon as I hand off to the speaker, who will share their perspective, and then we will have each of the other or a few of the other panelists respond to the perspective with ideas and solutions. When the time is up, the timer will ring, so you will hear a ding, and we will try to stick strictly to these times throughout the session. Let's go ahead and get started. Okay, so to get us started, we are going to hand the mic over to Dr. Ahmadjan Naeem, who, as I mentioned, spent over 17 years working with Ministry of Public Health. And during this time, he worked closely with many donors. And as we all know, nothing has been possible in Afghanistan over the past 20 years without the contribution and support from donors who have invested over $80 billion in health and development of Afghanistan. So let's hear from Dr. Naeem and what he thinks some of the priority areas are when it comes to working with donors in Afghanistan. Dr. Naeem, over to you. Please unmute yourself.
Uh, Thank you very much, Nadia, and good morning, good afternoon, and good evening to all of you. Probably Afghanistan is a conflict-ridden country, as we heard, from Nadia. And one of my colleagues puts it that it's an interesting place to work. First of all, it's very difficult. Second thing, you never get bored because there are always challenges to face. And I'll be talking about, probably two challenges. One, if we look at the 2018 National Health Account of Afghanistan, the total health spending is about 2.59 billion US dollars, 75.5% is out of pocket expenditure, about 19.5 is contribution from the donor, and it's only 5%, that's was contributed by the previous government. And at the same time, this itself is, donor dependency. And at the same time, if we look at the decision by the World Bank on August 26, 2021, and they froze funding to the IEA, that's the de facto government, and then IMF and the European Union also, they stopped their support, so the health system collapsed. And after some time, other donors, they came up, to support it through 1 month, 3 months, 6 months, the contracts. That's how things were. And in the Lancet, it says that 43% of the GDP was supported by, it was the donor contribution. And that itself, fosters dependency. So the question would be that how can Afghanistan become self-sufficient? That would be something that we will be hearing, from our colleagues on the panel. And the second issue that I would like to mention is about the coordination of donors. In 2003, the consultative group on health and nutrition was established, and which transpired into a high-level oversight committee in 2015. But following the transition in 2021, there is no such high-level coordination. And recently, the development partners, they formed health sector thematic working group, which is developing a strategy from 2023 to 2025. And probably the question is now that there is no common policy or strategy to sign on to it, so that we make the best use of the scant resources that are available. Thank you.
Thank you, Dr. Naeem. Just 1 minute before we move on to the responses, there's a note here that the slides have frozen. Brittany, would you mind stop sharing and resharing the slides so that they can get going again if possible? Okay, hopefully that is fine. Please let us know if you cannot see them. Thank you, Dr. Naeem. So let's move on to our first panelist, who will respond to the ideas and challenges that you've raised with some proposed solutions from his perspective. Dr. Chopra, over to you. You have 2 minutes and the timer starting now. Thank you.
No, thank you, and it's a great pleasure to be here, and thanks for organizing this, Nadia, and it's a great honor to follow the great Dr. Hamid Naeem. Salam alaikum. And in fact, I'm going to jump to one of my last points, which is indeed the level of coordination amongst donors. And there has been, many factors. I mean, I think Afghanistan is one of the more successful examples of coordination, not least because of the fact that we're able to, as Dr. Naeem said, the World Bank had to freeze funding after August 15th, but within a few weeks, partners had picked up the baton and continued the financing, and we were able to come back in again in the beginning of the new year. And so there was actually, you know, the resilience of the system was has been quite amazing, and then some part of that has been the coordination amongst donors. Now, there's some good reasons for that. There is we have got a coordinated ARTF trust fund, the Afghanistan Reconstruction Trust Fund, which has facilitated that. Some things we're going to be talking about today, the packages of essential services. But I think the most critical factor has indeed been how was the leadership of people like Dr. Ahmed Naeem of the Ministry of Health and of the Ministry of the government. And they were very clear in their vision, very clear on their approach, and that gave the donors a North Star to sort of to organize around. So I think coordination of donors has been a relatively success story, I would argue, particularly in the health sector, and not least because of the leadership of the ministry. Regarding donor dependence, we could have a lot more to say about that, but I want to emphasize that actually 60% of health expenditure was out of pocket. So even though donors played a big role in the formal, in the health expenditure, actually the majority was people themselves.
Thank you, Mickey. Let us move on to Dr. Tonoli, who will give us his perspective on these topics from the WHO standpoint. Dr. Tonoli, over to you. You have 2 minutes. You are muted.
Thank you, Dr. Nadia. Good morning, good afternoon, and good evening to all colleagues. I will just add voice to what Dr. Mickey mentioned, that what we have seen that Afghanistan is dependent on the aid, and 2020 almost 43% of the aid flows is represented of the total GDP. Similarly, the health sector, as just mentioned, is also dependent on the aid. So there's no quick solutions to make sure to make that this will become aid independent. But what we can do is to better align and harmonize the aid and the priorities with the national priorities, to make sure that there's a proper harmonization. And secondly, also to make sure that we are involving in all the strategies and plans when it comes to the health sector transitional strategy for Afghanistan, all the stakeholders. I will also want to add here that the coordination structure, because as mentioned by Dr. Mickey, is a very good example in Afghanistan. These aid coordination architecture has been developed, and there is a health sector thematic working group which is co-chaired by WHO, World Bank, and USAID. This is a highest forum where they discuss all the main issues and the priorities for the health sector, whether it is humanitarian or development, whether it is the health emergency response project or the project under the humanitarian response plan for the current year. So this forum is also working to make sure that there is a policy and the strategic discussions at that level. And then at operational level, there are different thematic working groups which will also feed into this strategic work, and they are working on this. Moreover, WHO is working with all the stakeholders to develop a 3-year health sector transitional strategy, 2023 to 25, and all the stakeholders, and the donors are very much actively involved in this endeavor. Thank you.
Thank you, Dr. Tonoli, and colleagues, for sharing those important insights about donors and donor coordination. I think much more remains to be discussed here, but great to have an initial brainstorm and set of ideas here. Let's move on to something related to this topic. So we've talked about donors. Donors are investing in something. They're investing in ensuring that Afghans have access to healthcare through packages such as the basic package of health services and the essential package of hospital services, which have been in place in Afghanistan over the past 2 decades and have been revised a few times to align with population needs on the ground. And they've been contracted out largely through NGOs who are on the ground providing these services to people who need them. However, these channels are not without their own issues and set of challenges. And though they have been successful, there are things to discuss here. So I'm going to hand over the mic to Dr. Mickey Chopra, who's going to walk us through some of the priority challenges in these areas for Afghanistan. Dr. Chopra, over to you.
Yeah, no, thank you. And as you said, Nadia, one of the innovations and sort of global leadership that Afghanistan has shown was indeed with the development of these packages, essential and basic packages of services, which are very much in line with the burden of disease, as well as an equity and focus on women and children. But these were developed a number of years ago, and there's obviously a need to continually update. And so a challenge, and obviously the epidemiology shifts as well. But since we're not collecting detailed burden of disease data, there's a lot of modeling that goes into some of this burden of disease. So it does open up for controversy and discussion, and we can get into some of the specific technical details of that. But I mean, so for example, many have quite rightly pointed out mental health is not there, trauma care is not there, NCDs in general are not underrepresented. But there is this sort of weighing up between prioritization of existing packages versus new additions and cost. But not just financial costs, but also the capacity and the human resource and technical capacity for these things. So I think just as important as a technical discussion, perhaps is the process discussion of who gets involved, who has the voice, and what weighting we give, and the processes for that kind of discussion to happen, which so it's tended to be mostly at a technical level, and not so, and we haven't paid enough attention, I would suggest, in terms of the process itself. Just briefly on the features of the NGO contracting, which is indeed another key innovation of the approach in Afghanistan, as you pointed out in your introduction. And within that, I think there's been a really amazing iteration and learning process that's gone on. So it's not as though there's one contracting process which was started in 2006 or whatever, and it's been frozen. There actually has been iterations and innovations within that contracting, not least the increasing focus on performance-based contracting. Most recently, the pay for performance element to it. The mix between, lump sum versus performance has been a live discussion and debate. The bidding process itself, and to what extent bids are made according to costs versus technical efficiency versus historical and performance. These are all issues which have been controversial, but what's been really wonderful about working in Afghanistan is how it's all been in a very learning environment and a very open and honest discussion and debate environment. So I think as a result, there's always been, I like the word you used in the beginning of your title, evolution. And so that's been a really important part of the process here.
Thank you, Dr. Chopra. And nicely laying out some of the issues and considerations that you all are thinking through in the next phase of these innovations and implementing them in Afghanistan. So to start the brainstorming session here on how we can think about solutions for some of these issues you've raised, I'm going to hand over the mic to Dr. David Peters, who will enlighten us from his perspective. Dr. Peters, over to you.
Thank you, Dr. Aksir. And I'm really happy to be here. It's great to see so many old friends and colleagues online. I also want to say that it really takes some humility to try and discuss solutions from the comfort of my office in Baltimore, and that I have great admiration for those who are working in this current situation, and particularly those that are in Afghanistan now. I think Mickey makes some excellent points about the BPHS and the EPHS packages and how they do need to evolve. I think it's useful. It's helpful to coordinate standards across providers and levels of care. And, focusing on a package that can actually be delivered is really important. But I think we have to recognize that this is a transition strategy, so you need participatory process for legitimacy, and eventually you need a transition strategy to have an Afghan policy and a Ministry of Health to legitimize and sustain it. On the NGOs, this has been an area of contracting in Afghanistan since 2004, really 2003-04. I think we've learned a lot about this. At the beginning, we learned that it can work in the worst difficult circumstances, various forms of contracting. Originally, the performance bonuses didn't do little, but we know design matters. NGOs need flexibility to use funds the way they need them, but to have really fixed, focused deliverables, including performance on equity, including using CHWs to make it work. We also know, in addition to design, you need implementation is critical to do it with. You need health workers who know they're getting their bonuses. They have to be sufficient size. We know a lot of what that means, and you can't neglect the demand side, what's happening from the population. So there's a lot that has been learned, and I'm glad that they're progressing in this way, and look forward to that being not just a transitional, but even a long-term systemic approach to things.
Thank you, Dr. Peters. I'm going to hand over the mic to Dr. Naeem, who is going to also try to respond here with some solutions from his perspective. Dr. Naeem, over to you.
Thank you very much. And just to follow on, what was mentioned by David, and probably reimagining the basic package of health services and essential package of hospital services. This discussion has been taking place for quite some time based on the 2010, probably it's an old data, but that's the only Afghanistan mortality survey that was conducted, where we had 35% of the burden of chronic diseases and 15% was injuries and trauma. So if we add that up, it forms about 50%. So for the epidemiology has changed, and therefore it would require a revision. And since more than 10 years, the basic package has not been revised.
I think we lost Dr. Naeem. He may have weak connection. Let's give him a second here. Okay, no worries. We will come back to Dr. Naeem at the end if we have time. So let us move on. It's really good to hear about the BPHS and EPHS, the successes, and of course the challenges that remain, and much remains to be done with these packages. Now, in order for these packages to be executed and to be implemented effectively, we need people and we need supplies. And now we're going to dig into this discussion a little bit more. Starting the conversation will be Dr. Jamshed Tanoli, who is on the ground with WHO in Afghanistan, dealing with these issues actively of how to actually get health services to the people who need them. So Dr. Tanoli, over to you to highlight some priority challenges in this area.
Thank you, Dr. Nadia. The health systems in Afghanistan, they are hampered by multiple challenges. As we understand, there are different components of the health system, but two important components, which is the health workforce and the essential medicines and supplies. These are the foremost and the greatest challenges. I will touch upon basically on these two challenges. There is critical shortage of the qualified health workforce in the country, and according to the WHO benchmark, to have a 23 qualified health workers per 10,000 population, while in Afghanistan we have just 8 to 9 healthcare workers per 10,000 population. And even these workers which are less in numbers, when you look into the ratio or the percentage of the female health workers, they are less than 30% of the overall workforce. And most of the female health workers, they are in the urban centers, and the rural or the remote areas don't have female health workers. Similarly, even the male health workers, they are mostly also concentrated because of the shift from they prefer to work in the cities rather than to go in the underserved areas. Second issue is the maldistribution I just mentioned of these workforce. Mostly there is immigration to the cities. Apart from that, there is also immigration out of the country. Much of the qualified health workers, especially those specialized fields, specialist doctors, they have left the country for different reasons. The second issue, which is about the availability of the essential medicine and supplies. When we look into this has two angles. There is less quantity and also the quality of the medicines which are available in the market. Afghanistan is dependent on the import from the neighboring countries. Most of the medicines, they are imported from the neighboring countries, and even the raw material for some of the manufacturing units is also imported. There are various channels, legal and illegal channels, through which these medicines are imported. What we have seen that all the health partners or the NGOs who are delivering these services, they face huge challenges when it comes to the importation. And usually it takes 4 to 6 months for the medicines and supplies to arrive in the country and to reach to the warehouses. And then especially during seasons, different seasons, the winter season, it is also difficult to make sure that the medicines are available in the deep field. We have also seen about the usage that there is over-the-counter sale, which has risen the antimicrobial resistance in the country. So we have to make sure that we are focusing to address these challenges. Thank you.
Thank you, Dr. Tanoli. Some really important issues that you've raised. To start the discussion on solutions, I'm going to hand over the mic to Dr. Naeem. Dr. Naeem, over to you.
Yeah, thank you very much. And thank you, Dr. Jamshid, for raising the issues. Human resources has been a problem since 2002, especially the female health workers. And probably after the August 15 transition, there were many of the health professionals who left the country. So there was brain drain. And what can be done to have the necessary staff? First of all, we need to incentivize them, especially the female health workers, to go to remote areas and serve over there by providing them accommodation, the incentive, the hardship allowance, working on their career development, then providing them training, transport during their holidays. So that would be something that we could do. And then at the same time, we also need to do in-service training for the current staff. For some provinces, they do not have the gynecologist and obstetrician, probably for short-term deputation, for example, for a quarter. The female gynecologist could be sent to the provinces. Every 3 months, they could come back. For the long term, we need to encourage some girls, and establish a bridge course for them so that they can compete, and then they enroll into the middle school. On the medicine, currently we need to, in the short term, to strengthen the pharmaceutical supply chain management working group, which has started establishing a list of critical medicine quantification for the country.
Please finish up your point, Doctor.
Oh, okay. And then for the long term, probably we need to have a regulatory framework to ensure quality and safety, establish a pharmaceutical supply chain management system, and establish an information system that's pharmaceutical logistic information system, and work on rational use of medicine. Thank you. Over.
Thank you, Dr. Naeem. I'm going to hand the mic now to Dr. Peters, who is also going to share from his perspective what some plausible solutions might be for these areas. Dr. Peters, over to you.
Thank you. And I think the points made were really excellent ones. I mean, I would point out also that issues with human resource for health and essential medicines were chronic and critical problems even before the regime change. There were steps taken in the right direction, and many of them, particularly around human resources, rely on peace, security, and stable governance. I think in the short term, it's really critical to ensure that there is safety of health workers. and especially for women and those working in remote areas. And you do this not with guns, but I think with building trust in local populations, but recognize it is issues. It is a real important issue. In the long term, I think that you need to look at all parts of the human resources life cycle. So production, let's not forget the production of nurses, doctors, community health workers. Recruitment, I think, again, focusing on local recruitments to work locally is critical. Retention often requires safety and ensuring that people can meet their basic needs, get their salaries on time. Real, critical, but bread and butter types of issues, or non type of issues. In terms of performance part, I think supportive supervision, and actually critically supervision of supervisors, is really important to help health workers fulfill their jobs. Central medicines, I totally agree with what's being said. Pretty well every country of the world relies on imports and active ingredients that come from somewhere else. So building effective, trusted regulatory institutions is not easy, but it does take long-term strategies and partnerships to be able to do that. But in the meantime, you try and have solid supply chains within the NGO system that's there. Thanks.
Thank you, Dr. Peters. Just a quick note in the chat. Thank you all for your comments and your introductions. If you have questions, please do put them in the Q&A, because then they will be moved forward to our list of questions. If you don't mind, please do move them to the Q&A section. Thank you. Okay, so we're going to move on to the final topic here that we're going to discuss, again, to Dr. David Peters. So all this is important, of course, and what's equally important is to make sure that we're collecting good data, good quality data, and using that data effectively to monitor our progress and to set benchmarks and targets and to ensure that we can get ourselves somewhere. So to talk a bit about the issues around data and using data for decision making, I'm going to hand the mic back to Dr. Peters, who will share this from his perspective. Dr. Peters, over to you.
Thank you. Thanks very much. And I think it really is critical that we see good quality data, not as an exercise for its own purpose, but really as a means to an end, to drive strategy, to demonstrate how things are working to solve problems. You need transparent, publicly accessible data in order to do those things well, to build trust in systems, to allow health workers, whether they be at the facility or at the provincial or central level, to support decision making, and to be able to answer some of the questions, frankly, that are in the chat about opinions about how things work. I mean, data really helps us show how well the different kinds of collaborations, contracting has worked in the past. And the good thing is that, back in 2003 and 2004, when the HMIS system was destroyed, they were able to build it up over time. And so it can be done under really difficult situations. And I'm confident it can be done now. But again, you can't fatten a cow by weighing it. The challenge is you want to use the data to an end, and it's really about building trusted services that have an impact. And that's really going to be the key. I like the way the WHO dashboards are now being used already to show what's going on. That's really important. But we have to move away to, or in addition to focusing on the supply side, eventually you want to be able to show what's happening in the population, on quality of care, on the outcomes. And that's really what's going to be critical. In the long run, you also need government commitment to be able to do this. So the challenge is to create data that is useful in pretty emergency situations, but also for the long term, to be able to address that changing burden of disease, for example, and as well as to ensure that you have accountable decision making. So that's what the real challenge is. We know the technology of how to be able to do this. Sometimes it's difficult to do it when the actual ways of getting from place to place and collecting data is unsafe. But you need to, the challenge is, how do you do this unless you get government commitment and partnerships to build trust between health workers and populations, and to rebuild the kind of systems and capabilities to implement them, and to not only create the data, but to use the data in order to improve services and outcomes for people from local to national level. Thank you.
Thank you, Dr. Peters. So I'm going to hand the mic over to Dr. Chopra now. You know, as someone from the World Bank who is a consumer of this data and acting on this data, we'd love to hear his perspective on the thoughts that Dr. Peters shared. Dr. Chopra, over to you.
Yeah, no, I'm not surprised to hear such brilliant comments from Professor Peters, not least because we really stand on his shoulders. He and Dr. Naeem as well with leadership to design many of the innovative tools, including that balanced scorecard that you saw there. And what was really encouraging, and Dr. Tanoli can come in on this, is that in the last period, this summer, WHO and UNICEF staff have been in the field checking on the data quality, or the routine data quality. And their findings from hundreds of facilities across the country have shown about 98% reliability and accuracy of that routine reported data. So this investment and the innovation in routine information has been phenomenal in the country, and has been the backbone of the whole success that we've achieved thus far. And I completely agree that having that investment in the quality, we need to shift a bit more now towards the use of that for decision making, and the more innovative use of dashboards and the better ways of collecting that we're working on still. One of the most exciting things of the new project, which is now in the field, the HER project, is that we've actually had a component to contract out to technical agencies to what we call management accompaniment, which is to work on a very much more closer level with the implementing NGOs to help them unpack and understand the data. So previously we assumed they had that capacity, and now we're actually explicitly providing them with technical assistance for them to understand what the data is showing to them, to highlight management systems that may need to be improved. So really trying to translate the excellent high quality of data into practical actions that NGOs can take.
Thank you, Dr. Chopra, and a nice lead in to Dr. Tanoli, who will also talk about these issues here from the WHO perspective. Dr. Tanoli, over to you.
Thank you, Dr. Nadia. I will pick up from where Dr. Chopra has left, that WHO is working very closely with the World Bank and, of course, with all the other donors of the HER project, especially to ensure that there is a good quality, reliable and accurate data. Because accurate data and the reliable data is very important to measure the health status of the population, and also to understand about the disease patterns in the country. So WHO is trying its best and working closely with the Ministry of Public Health to ensure that the systems and tools which has already been invested by different donors previously, as also mentioned by Dr. David, that these systems and tools are further strengthened, and also to make sure that the people who are running these systems and tools, they are well trained and their capacity is built. What we have seen also, there is a need to invest more at the field level, because at the field level, at the facility level, the data collection is still paper-based, while from the province to the central level, it is electronic system. So we want to make sure that we invest more, and that there is the availability of the real-time data when we will be having these further improvements from the field level and the health facility level. There have been good practices, as also mentioned by Dr. Chopra, by UNICEF and WHO for this HER project, and they're monitoring more than 2,300 health facilities, getting the inputs and ensuring that there is sufficient data to make informed decision. and also use that for policy setting. So this is what we are working on to make sure that the capacity of the staff is up to the mark to have a quality data for the decision making. Thank you.
Thank you, Dr. Tanoli, right on time. So thank you, colleagues and friends and panelists. That brings us to the end of the structured dialogue component of this session. We are now going to move into the Q&A. I see that there have been a ton of great questions that have come in. So we will select questions, and apologies if we don't get to your question in the next few minutes, but we will select questions and address them to each of the panelists. So the first question I have here is for Dr. Naeem. A question has come in. I think this is the big elephant in the room, of course. We are here talking about these issues, but what do you think is there, what is the role of the new de facto authorities in sitting around a table like this and having these conversations and getting involved in issues with regards to the health system and priorities and challenges and solutions and so on. So this is a question that's come in, and sorry that I'm handing you the difficult one, but I will give the mic to you to respond, and you have 1 minute for your response.
All right, thank you very much. And I think it's a really difficult question. I think we need to separate two things. One is the political issues, and the second one is technical and system building issues. If we think about the people of Afghanistan and currently the de facto government, they are in power and they are ruling the country, and without their involvement, sometimes it's becoming very difficult. Let's take the example of the Food and Drug Authority of the government, which is a very important organization and institution. If that's not supported, probably we will have bad quality drugs, counterfeit medicine, and the food quality will also be similarly, which is affecting the children and women and the whole population in the country. So therefore, their involvement would be required up to some extent. Thank you.
Thank you, Dr. Naeem. Okay, next question is to Dr. Chopra. So Dr. Chopra, many audience members are wondering what happened to the Integrated Package of Health Services, IPHS, and is there any scope for implementing that in Afghanistan today?
Yeah, no, thank you. And thanks everyone for some great questions. Absolutely. So that's what I was referring to, that there has, there's been a recognition that we needed to update the packages. And as I mentioned, the IPHS has highlighted some things that could be added. And so the challenge for us has been, there's a financial aspect, but the bigger challenge is really the capacity, the human resource capacity, and the systems capacity to add additional aspects to the packages as well. So we've been waiting for the system to settle down again. So this period, as was mentioned by one of the other panelists, we are going through Dr. Tanoli, I think, a interim strategy development process for the next 3 years. And as part of that, we are doing another costing and looking at the capacity and the feasibility of expanding the package.
Thank you, Miki. My next question is for Dr. Tanoli. So Dr. Tanoli, many audience members are wondering, of course, the big issue around women's access to healthcare and all the factors that determine whether or not they can get access to healthcare. From your experience on the ground now, how has the situation around women affected health outcomes for women? And also, do you have any ideas in mind for how we can encourage female healthcare workers to remain in the workforce?
Thank you, Dr. Nadia. Very pertinent question based on the environment in the country. As I mentioned in my presentation, that there is less number of the female health workers. But to give you a very good example, that after 15th of August last year, what we have done as a WHO, that we have a presence of polio staff in almost every district of Afghanistan. So we did a survey following, on weekly basis for all the health facilities. And we found that in 92% of the health facilities, there were female health workers. This doesn't mean that there were sufficient. This means that there is a midwife or a female nurse, or maybe only one female at the sub-health center level or at the CSC level. But what we found was that the female health workers were present. I did an analysis of the monthly achievement by the health cluster partners, and I found that there is no drop in the number of the females reached during this previous months, as compared to before 15th of August. So women and girls, they were still also accessing the services. But what I said, the challenges that we have to improve further, and we have to increase the capacity of the existing health workers, female health workers, and we have also increased to make sure that there is more production of the midwives and the female doctors in the country. Thank you.
Thank you, Dr. Tanoli, for continuing. I was just messaging my colleague to say to put another minute on the clock for Dr. Tanoli, because I think this is a really important area that needs more time to discuss. So thank you for continuing on. I'm going to pose a question now to Dr. Peters. Dr. Peters, we have a question here that's asking about how can we improve data sharing between donors and NGOs so that we can avoid duplication of efforts and really make sure that we're all speaking and understanding and working with the same data?
Oh, great question. I think it really does involve those processes that were referred to earlier about getting consensus around what services are important, and then how do you measure them, what outcomes you're reaching for. That's how the balanced scorecard was put together. It was a lot of service providers, NGOs, government, and donors coming together. And when you have publicly accessible data, that's important, because what you're trying to do is to build trust and accountability, but also learning. And you do that by showing benefits of sharing data and using data. And there's many ways in which that happens. And there's nothing like the experience of actually generating data and using it to solve problems, to improve things, to identify things that need to be worked on. That really is the pathway. So take some leadership. You'd like it to come from government, but in the meantime, I think you have to work with all of the stakeholders to try and be as inclusive as possible.
Thank you, Dr. Peters. I have another question here for Dr. Naeem. So a question is raised here about, given the new realities in Afghanistan, and the presence of the private sector, what role do you see the private sector having in health in Afghanistan moving forward?
Thank you very much. If we look at data, that a few years ago, more than 60% of the patients were going to the private sector for care. So therefore, they have a very important role. Those who can afford it, probably they can use, and they are using the private sector facilities, which is probably freeing some resources to be spent on the poor and those who are not able, to afford private sector services. And they have been, they have an open hand in bringing changes, improving quality, and so the inequality improvement. Though they have problems, but I think they can bring new technology and the new services to the country. And some of them, they are already certified, like the FMIC, and we have Cure Hospital, which are ISO certified. So the others could also be certified gradually. Thank you very much.
Thank you, Dr. Naeem. Dr. Chopra, I have another question here for you. And you touched on this a little bit. So we know that out-of-pocket expenditure on health is very high in Afghanistan. How does the donor community consider these high rates of out-of-pocket expenditure in Afghanistan? And what are the plans to address this, if anything, moving forward?
Yeah, it's a difficult one because as your previous question and Dr. Naeem responded, part of it is the private sector and what's happening in the private sector in the last period of time, which we don't really have a great deal of insight into. So I think first and foremost, a lot of our data was pre-August 15th last year. So we really need to do some work in terms of understanding the situation in the private sector at the moment. And probably do need to collect more household data to get a up-to-date reflection of what, whether people do even have access to private sector for out of pocket. I think our focus remains that if we can provide high quality, free at the point of care, public health services, particularly for women and children, that is the priority aim for then minimizing the out of pocket for those things at least. But I think the short answer is that we don't know enough. We need to get updated in terms of understanding what the out of pocket is now and what the private sector is doing.
Thank you, Dr. Chopra. Dr. Tanoli, a question for you. So you've mentioned, we've all kind of discussed this. There's a brain drain. Many skilled professionals have left, yet there is a shortage of healthcare workers in Afghanistan. What do you think, is there any scope for Afghan health professionals who have settled outside of Afghanistan in the diaspora communities to reintegrate into the health workforce in Afghanistan, either remotely or through other means?
Thank you, Dr. Nadia. Again, a good question. What I've seen here is a good example of the e-learning and e-consultations. What we have seen here is a French hospital, which is for the maternal or the mother and the child. And they are linked with the couple of other hospitals in the country, apart from the hospital outside the country, with our Khan hospitals. I think we can learn from them how to use these diaspora or the doctors, who have left the country, the specialists, and to make sure that, how they can give services to the Akhwans. And of course, it will require technology, and it also requires some investment in that field. And it also requires some sort of understanding with the big hospitals, especially whether at the regional level or the provincial hospitals level, and especially the doctors who have left from those hospitals where they have left, they can contribute. So it needs a further analysis and study. At the moment, we don't even have the number, of the doctors who have left. Of course, there are different numbers floating. Some people are saying, it's more than 20,000. Somebody are saying 10,000. So there is no exact number how many doctors have or the health workforce, they have left the country. This is very important area to work on this, to do a proper assessment, to know how many doctors has left of different specialties, and then to also look into how to involve them and to utilize them and utilize their services for the people of Afghanistan. This can be discussed, of course, with multiple stakeholders, because this might also require technology, as I said, and the investments. And it also requires, the consent of those doctors who have left the country. But this needs, of course, further research and the analysis and the discussions with the different stakeholders. Thank you.
Great, thank you, Dr. Tanoli. And that brings us to 2 minutes left in the session. So I just want to take the opportunity to thank our esteemed panelists for their taking out time out of their busy schedules and important work in Afghanistan to be here with us today and share their critical insights and have this brainstorming session live in a public platform where all of us can listen and really engage and take part and get excited about some of the things that are possible for Afghanistan moving forward. So thank you so much, colleagues, for taking the time to be with us today. And I want to thank all the audience members who again took the time out of their day to connect and to listen in. I really appreciate you joining and all the thoughtful comments in the chat and also the questions. Sorry if we didn't get to all your questions, but hopefully some of them were addressed here today. If anything comes to mind after the fact, feel free to drop any of us organizers an email and we can continue offline as well. Just a few closing reminders here. Please do visit our Mission Afghanistan 2030 page for more information about the upcoming sessions, the 3 sessions that are planned, and you can register there as well. We will be sending out the session recording, so please watch out for that. And do circulate our sessions widely in your networks. We'd love to see all of you again and more of you join the future sessions as well. So thank you once again. Thank you to the panelists. Thank you to the organizers who are working on this with me, Sama Albaz and Brittany Fergal. And thank you to all of you who've joined, wishing you a blessed and good day ahead. Thank you all. Take care.
Thank you all. Thank you. Thank you.
Thank you all. Bye.
Bye-bye.